You good, Ryan?
Yeah. All right, so we'll kind of shift to the Navy Marine Corps, and it's a little bit different. Like Dr. Reed said, I think a lot of the philosophies are the same, and so you can use some of the same principles, but the processes are a little bit different and more complicated. Dr. Reed made a point, next slide, made a point about 4 decisions, and I have a slide, 5 decisions. And so I think I captured all of your 4 points in this. Disclaimer, like Lance said, this is kind of my own experience. I didn't really get a class on this when I was in GMO, so I just pieced together from the regulations and kind of what worked for me, and nobody really complained, so I just kind of kept doing what worked. But if you have done stuff that is different, or if you have a different read of regulation, please interrupt me. This is just kind of how I think this. And again, these things do change, and so I encourage you to verify what I show. And I made a few flow charts and summary statements, and those are my own. So these are the objectives I want to understand what a physical evaluation board is, and how that kind of factors back into the limb duty, light duty, and the decision making that goes on with that. And then identify people who are appropriate for a physical evaluation board and a referral to that. And then the last part would be to be more comfortable, increase familiarity with the process of actually submitting a board or PEB in the limb duty smart system. So the jargon can be a little bit confusing, and it confused me for a long time. So you'll hear a lot of talk about med board and MEB and PEB. As best as I've been able to figure it out, med board is just a colloquial term, but MEB is a medical evaluation board, and PEB is the physical evaluation board. And the medical evaluation board convenes and really it's at least 2 providers, and it dispositions certain members into either full duty, limited duty, or referral to the physical evaluation board, which is a body that makes a determination about sort of like retainability or fitness for continued naval service. The medical evaluation board is kind of a step before that and can result in a limited duty. So if you read the instructions in the manual, it'll talk about MEBs and medical evaluation boards leading to limited duty. And it makes the distinction between that and the physical evaluation board as a more terminal process. Just go back one more, sorry. So as a frontline provider, you will be participating in an MEB as one of those 2 providers. And when you submit limb duty and limb duty smart, like we discussed last time, you submit it as yourself, and then that goes to another provider to co-sign, and that's the medical evaluation for those 2 people. For a referral to a medical board or to the PEB for a more permanent disposition or duty status determination, that would involve you and then amoeba as a senior provider to review what you wrote in the NARSIM and all those things we'll talk about in just a few minutes. So this is my flow chart that I made. And I broke it down into these 5 decisions, but I think they did capture all of what Dr. Reed was just talking about. I took this from a lot more complicated flow charts that were in the MANMED, and MANMED chapter 18 is the go-to for all this stuff. And if you look at it, it's really hard to follow. It's all black and white. It's all these like curved lines. You have to go from one to the next. I think this captures most of it and does it in a little bit more digestible way. But I made this, so it's not official by any means. The first question really is, and we'll kind of go through the whole process a few times with different cases and stuff, but the first question is, can the service member return to full duty? And that's kind of the key question you ask at every encounter, like Landon said. If they can, it's easy, right? They go back to duty. But if they can't, then you have to just keep going down this flow chart. The next question is what you're dealing with a relatively minor thing that you anticipate to resolve in the next couple of months? And if it is, then light duty is probably appropriate, like we talked about last time. And you would do at least every 30 days a reevaluation. You do the light duty in 30-day increments, a reevaluation at least every 30 days. And then every time you ask that same question, number 1, which is, can they return to duty? And if so, gluten, no, you just kind of continue that process. As long as it's still a minor issue that it's going to resolve in the next few days, a few months. If we're beyond that, if we're something that maybe isn't going to resolve on that, it's more significant, then decision number 3, which is the condition that we're discussing appropriate for a medical evaluation? And Landon talked about that quite a bit. Generally, the same rules apply for the Navy as they do for the Army, from what I can tell. There is a list of conditions in the man-med that are felt to be not for a medical evaluation. We're going to get to that in just a bit. So if they're not, then you go through other channels. But if they are conditions that are appropriate for a medical evaluation board, then you go on to the next block, which is that board convenes, and that can be just 2 people. And it can be done virtually, convenes, maybe stronger. And the question is that, is the condition that you're discussing permanently incompatible with continued service? And if it is, permanent PEB. And if it's not, is it going to get better in a year? Because if it's not going to get better within a year, based on your clinical judgment, it pretty much is permanently incompatible. And then you're back to the P. If we think that we can make some progress and get somebody back to a full duty status within that year, we can do our 2 periods of limited duty, of course, 12 months now of limited duty, with again, Q30-day reassessments to make a determination depending on where we are in that process. If at any point in that process you feel like they're not on track to getting back to a full duty status in that total of 1 year time frame, you can always go ahead and submit the PE at that point. So what I did is I went through each of these decision points, these 5 decisions, and kind of put the relevant references that I think that you can use to help answer those questions with some of my own commentary. So the first decision is, can that person that you're evaluating return to a full duty status? And there are a number of things to help make it. And so Chapter 18 of the man-med is probably the go-to for almost everything here. But there are DoD level, Navy level instructions that also can assist. So M1850.1, I'll talk about that a little bit more in just a minute. There's a 6490.07 is a DoD instruction. And then there's the DoD clinical practice guidelines for deployment limiting mental disorders and psychotropic medication, which has been really valuable. Does anybody use that, reference that? That I think is a really nice document that summarizes a lot of things. And while I've noticed a lot of these different instructions or resources do leave a lot up to individual providers and their clinical judgment, which I think is a good thing. It gives us all the ability to use our clinical judgment to make these decisions. So these are direct quotes. So that first bullet point is from the man, and I think it's pretty much a standard question you can ask, to make that determination for yourself. Is the person that you're treating able to be in a full duty status? Do they have a condition that appears to significantly interfere with the performance of duties appropriate to their office, grade, rank? If they do, then probably. But then also look at the other things that are up here, because these instructions will give specific requirements, recommendations about who can deploy. And in the Navy, in the Marine Corps, especially the Marine Corps, part of being in a full duty status is being worldwide assignable. And if you go to like the logistics unit where I was, they'll frequently have people come up for individual augmentee appointments to go deploy with an adjacent unit, and it can happen in like 72 hours. Or somebody falls out of one of those things and needs somebody else to come in. And so if somebody just doesn't have the paperwork that says that they're in a duty restricted status, and they get picked for that thing, they're going. So reference these things to answer that first question. It's kind of a takeaway from this. But that first bullet point is probably the most helpful to kind of get you to do an internal check and get you on the right track. Then we're on to decision number 2 here, which is it a condition that you anticipate to improve in the next 90-ish days? And that's, I think, primarily a clinical question. That's why you go to medical school and residency to answer those kinds of things about what do you think is the natural history of this with treatment, with these different modalities that you're going to employ. But the MANDAT does lay out some things that can help you with that. And these are the bullet points that I took directly from the MANDAT that you can reference that help you say, is this something that, given the specific requirements of military service, in the Navy and the Marine Corps specifically, is this condition likely to continue to lead to rehabilitations over that that period of time, or is it going to go longer than 90 days? At which point you're talking about more of a 50 days approach. So those are your first two. Your third decision is the condition appropriate for an NEP. And there's a bunch of things out there that I was able to find. Some of it appears to be canceled and outdated. And one of the frustrations that I have is it's not always clear what things are old, what things are still in effect. And sometimes the new instruction will say this cancels the specific instruction, and sometimes not quite so clear. But this is the old instruction. And it lays out these things as being things that are probably appropriate for medical board. This is the new one that replaces that. And so if you hit these wickets, the condition you're talking about is probably suitable for a medical evaluation.
It's on the previous slide that eating disorders were described for someone with an eating disorder that's causing them to gain weight, which would be make them unable to effectively perform their duty. Would the eating disorder, for example, be medicable given this Navy guidance?
So this is an old, just to be clear, this is the old instruction, but these are conditions that are appropriate for medical evaluation. So an eating disorder that's unresponsive to a reasonable trial of therapy or interferes with satisfactory performance of duty, binge eating disorder that leads to being overweight that you can't complete a fitness test. Based on this, and I think that my point really is that this is more restrictive than the new instruction. So I think either way, that's probably an approach. So this is like I was saying, this is the new instruction that's a little bit more general, doesn't specifically delineate things, but it kind of speaks to Landon's point that generally the default is probably going to be these conditions, and you have to kind of convince yourself, convince people around you that the condition, if you don't think somebody is suitable for a medical evaluation, or why you think that. And then the instructions, the evolution of the instructions, address that. And if you look at the MANDAT chapter 18, I think this was an informative quote. The primary consideration of whether an MEB should be convened is the judgment of the attending physician. So you can look at all these things, all these instructions, but really it comes down to even the instruction itself. In the MANDAT, it says that it's up to your judgment. If you look at 1822 and 1823, and I put a screenshot of that in, the next slide, it lays out very specific conditions that are not MEB, and that's part of this. Non-compensable conditions, which will generally mirror this list, so that the VA has a list of compensable conditions that have to be the service, so you can go and be evaluated for disability rating. Things that are not on that list, which are few and far between, are generally separated through channels like these. They're not separated through the evaluation board. They're usually separated through the administrative process. So that answers question number 3. Is it suitable for a board? And if it is, then you go to question number 4. And is it a permanently incompatible condition? And kind of like the Army flowchart we saw before, psychotic disorders of any variety and bipolar disorders, 1 or 2, are permanently incompatible with service. But I think if I just go period there, I can't think of any circumstance that's not the case. And really listed again clinical questions. If you make these diagnoses based on your clinical acumen, the PEB is the right answer. But if it's not permanently incompatible, then you go on to the assessment of, is it going to improve in a year? And so this would be things that are maybe not psychotic disorders or bipolar disorders that in and of themselves are sort of fundamentally incompatible with continued service. But we think it's going to go on for a long time, the protracted recovery, because of the severity of the response to initial treatment, whatever it is. Those things are functionally incompatible with service because of their natural history. And these things may require a degree of limited duty to assess that. So you have someone assigned limited duty, initiate a trial treatment and see how they do. And if they do well, then great. It becomes apparent in that initial limited period that they're not going to be back to a full duty status within a year of starting. Then it's time to consider it. So the PEB process is a lot like LIMDU, and it's done in the same interface, LIMDU Smart. And this is the general flow of how it goes. So your primary provider, that's usually going to be you, seeing the patient, making your clinical determination. You submit your clinical thoughts, the picture via LIMDU Smart, to Amoeba, a medical evaluation board approval authority, and they co-sign it. And then it goes to the specialty providers if needed or convenient. So again, it's the same website that we talked about last time, LIMDU Smart, and so the same access that you need. I think you do need to request access to the it's called EMEB, Electronic Medical Evaluation Board, EMEBR. And if you, where it says my name there in the top right corner, you can, that's a drop down menu, you click down on that, and then it comes down and it includes LIMDU, CND, which is the AdSet module, and then EMEBR, which is the PEB network module. But you pull this website up, and then if you are in the MEB module, the EMEBR module, when you search somebody's name or DoD ID, they come up. Like if they're in active naval or Marine Corps service, their name will appear there. The LIMDU system, you have to add in the EMEBR module, will come up. I searched myself, and I was going to try to run through it like we did for LIMDU to actually show you how to input yourself or somebody else in there. But it wouldn't let me do it without actually putting myself on a netboard. I was tempted, but I didn't do it. So I tried to take screenshots from the training program they have. So I'll run through that in just a minute. You search somebody out here, and then you can search, your name comes up, you click on the name, you can go to the next slide. And so then you have these options, and you initiate EMEBR, and that will bring you to the actual EMEBR interface where you can put in, you can go to the next slide. So it's not great because I had to copy and paste this from the PDF that the website has for training, but this is the first page that you see. And you input your diagnoses, and when you do that, you have to then select, is the member able to are they able to manage their own affairs? Usually it's going to be yes. And so then this one, no, is checked. You check yes. And then is it a catastrophic? And usually for all the ones that I've done, and probably for most ones I've looked at, the answer is no. They do not have a catastrophic injury or illness. And then you go to the next page. And then you enter in specific restrictions. Now, it used to be that when you did this, they were placed on a functional LIMDU with these duty status restrictions. So you actually type in here what we recommend in terms of PFT, CFT, or PRT in the Navy, other restrictions, no deployments, no field duty, whatever you think is appropriate, no weapons. You can put deployment limitations, shipboard field duty limitations, combat duty limitations on those radio buttons up top. And it used to be that would initiate a functional period of LIMDU for somebody when you put this in. For the end of my time on the unit, we had to put a separate limited duty package in as well concurrently to make sure that they were in a duty status restricted status. I don't know if the case here, how that's changing, that seemed to be kind of in flux. I would just check with your med board's office, wherever you end up going, to see if they want you to also initiate at the same time you put them. But this will be the same restrictions. If you have to do that, you just copy and paste here into a new package. Then you hit sign, and then you sign it as kind of the first member of the medical evaluation board. And then we'll bring you to another page once you save the patient. And then you'll see this. For every diagnosis that you put in, you have to put in each diagnosis that you make that you think is a avoidable condition. Then we'll bring you here, you can pick and drop down menu each diagnosis to have a new menu, and a menu up top, and you click on narcissism. And that's the most important next step after you as the treating provider evaluate the patient, initiate the team member, put in your duty status restrictions, do limit if you have to as well. The narcissism is the most important next step. So you click on the narcissism. And the narcissism is short for narrative summary. And the narrative summary is a clinical summary, kind of your rationale, your thought process, and the clinical history of the avoidable condition. So it's why you think this condition makes this person not likely to get back to a full duty status in the time when that would be appropriate for what the Navy considers that 12-month period. And it can be a good check on yourself to go through Malta, figure out what has been done for this person, figure out what were their initial presenting symptoms, what trials of therapy were done, how they responded to those therapies. It's a relatively short summary, but it's your argument that this person has met that MRDP. I haven't read that term before, MRDP, that maybe it's more of an Army thing. But it's kind of the same thing. It's you making the case to the other member of the medical evaluation board, this person is there, and why. This is the narcissism page. So this is where you actually type in your narrative summary. Sorry, you really can't read that so well, but these are all some of these out. So on this page, that the top says diagnosis, and then has an initial onset. And so when I would write these, I would go back and I would often not have seen somebody for the majority of their course of a condition that led to a med board referral. I'd go back and often find when did I perceive for this condition, if it was knee pain or whatever. Put that in there as the initial date. There's a box next to it that says combined effect. I haven't done a lot of psychiatric med boards. I'm not sure how that would factor in, but oftentimes with MSK med boards, if somebody has low back pain and knee pain, for example, are those two things related to each other? So combined effect. And you can check yes on that. And then the radio button to the right is warrants or does not warrant referral to a PEB. If you're writing this, you probably think that it does, and so you can check warrants referral. The next check mark down there in the next row is sensitive information. So if you are going to be putting something into the narrative, something that you feel like is especially sensitive, you can check that box. And when the paperwork gets forwarded to the command for review, those things will be left off of that paper. Whereas in that used the most are things like sexual assault reports or things factoring into those. If that factors into a clinical decision about the med board, that information for like the restricted report that had been submitted already, you can put that information into an Alta note, check sensitive information. It will block that out of the narrative summary, and you can say see Alta note dated. Yeah.
Who's the audience for the narcissism, and see it, and how detailed should that typically be?
So if you can you actually go to the next slide. So when you can read this better on a handout, this outlines some of that. So generally, I believe that the narcissism does make it to the command deck. The command has to fill out something called the non-medical assessment. That's sort of as you get further into the process, there are commands evaluation to service member. In general, what this text says is that generally the information in the narrative summary is considered to fall into the command exception with regard to HIPAA. especially with psychiatric med boards, there would probably be many cases where you'd have especially sensitive information that maybe isn't relevant, and the command doesn't need to know that information. If I had any concern about that, I would just put it in, I would mark sensitive information and put it in a separate alternate. Back just one. And then the bottom half of this is a little bit redundant, but it really asks you for clinical history, and then the actual three boxes toward the bottom are asking you about prognosis in, I think it's 3 years, and prognosis in 5 years. I don't really know why they distinguish that, but I would give a general picture. Where do you think this is going? Why do you think they're not going to be back to a full duty status within a year? Like I said, this is just talking about the use of that sensitive information box. And so you can review it. The text there says that it lays out kind of what, when, and why that might be. Yeah.
Derek, I don't know if you know if this is command dependent, but I think I only did one negative MED in third year, and I didn't do an RSM at all. I don't know if anybody else does that around here, but because basically just a sheet gives the diagnoses, and that was what I did, and it kind of made its way through. I don't know if that's typical or just here thing or.
I can verify I've done a few, this exact same, there was like a little section where you put down your assessment, or I guess your NARSM, but
Yeah.
nothing like this.
So NARSM, before we integrated and we had the AD offices, used to be now like pages and pages and pages. And now we're just giving them sufficient amount of information. This should not take you out, right? You're just putting it in there. And then personally in my practice, in my note, the day when I put the permanent profile or preferred MED, I do put in what are the diagnostic criteria for that condition, what are the duty impairment limitations, and their prognosis and what therapy done. So that helps the MED. But they are the ones who are then generating the pages and pages of NARSM. That we call that, so previously the clinician had to do all of that, and then they hired people and it professionalized the process. So someone in the MED office can look through every single chart and summarize everything, and it ends up being like a 20-30 page document. So luckily we're spared of that.
When you do the MED rotation for like elective, that is what you do. You want to kind of pull all that information from that question.
Oh, so that's why she opened up that elected, huh?
Yeah, I definitely echo what Dr. Means, and I didn't spend more than probably 15 minutes writing one of these because it really is like a paragraph summary of why you think that work is appropriate. I wrote them as an operational provider for my unit. I would write them for people that were assigned in our unit. That was a point of contention. It seemed to me like sometimes we got the impression that the specialists should be writing the med boards, the NARSMs, and they pushed back on that. And so there has been like a history of like who should be writing these things, but they're very easy for this anyway. The actual further processing is much more extensive.
So the question that he brought up about prognosticating 2 to 5 years from now, who's seen TDRL evaluation? Right, so one thing that can happen is you could be retained. So often if you're a physician and you get med board, you usually get retained. So like you can still get something out of it, right? Or if you're a lawyer or something like that. But often you get separated, you could permanently get separated. Some people get put on temporary duty retirement list, TDRL. And then pretty much every year or so they show up and we look at them. And I've never seen anyone reporting, I'm good to go, I'm ready to go. So it ends up being, I think, costly efforts on part of this. But those people don't get released immediately, they're still kind of on the hook. I don't quite understand how they decide who comes out of it, but eventually all of them do. I've only seen one lawyer with litigation like that. Yeah, so there's an element of that they have to decide.
Thanks. Then you put all that stuff into the limited smart system, and then it goes to the amoeba, and the amoeba concurs or doesn't concur. And if they don't concur, it sends back to the initiating provider and asks for additional information or modification.
That there's certain RDP.
And that's the only place I saw it. Any other stuff, I was like, is there something? So, next slide. And then once you submit these, you can track in Limited Smart what the progress is on each of yours. So these are a few that I submitted before I left. And each of these steps is required before the completion of the whole medical evaluation board process. And so the initial referral goes in, and you can see like March 5th, and that was completed by June 6th, which is actually pretty good. That has picked up considerably. It was a year plus, a year prior to this stuff. So the tempo, at least at June, has increased. But you can track and see if you get any questions from command or anybody about what is the status of my stuff. Really, those kinds of questions should be going to PEPLO's physical evaluation board liaison officers. I'll make a point about that in a second. But you can keep an eye on what the progress is by going to the news. And you just go to that menu up there, MED personnel, and anybody that you submitted will populate in a big long grid.
Well, a quick question, can you go back one more? So, are you able to talk to who can and cannot submit MED in terms of, social workers, psychologists?
Yeah, so correct me if I'm wrong, anybody who has more experience in the behavioral health, medical specifically, forward.
I would say it's listed there.
Yeah, if you look at the bottom when you sign as the initiating provider, and this screen is the same no matter what you're putting somebody on a board for. So if you're boarding somebody for back pain, or PTSD or whatever it is, you'll see this. And the junior provider is that first member of the MED, the person who's seeing the patient and saying, I think this person needs to be further processed for either LIMDU or referrals for PED. That can be a GMO, a PA, and I think an ITP. Do you go back, can you? I think an ITP, yeah, an ITP woman can do those as well. With behavioral health specific, of course, if you go to the next level, sorry, one more. It's the one with the already. This one. Check this box if a doctoral level psychologist or psychiatrist is required for mental health diagnosis. What I've seen in the past is I'll have referred someone to a medical board for some kind of MSK, and then a psychiatrist or a clinical psychologist will write a mental health addendum, a specialty addendum to my referral if there is an additional diagnosis of mental health variety that it has its own set of restrictions. That also what you see, sir.
So in the Army, anyone, so here's the restriction. So doctorate level for temporary profiles beyond 90 days. Put someone on 90 days and then they need another 90 days. That has to be co-signed even if it's temporary profile by a physician. For permanent profile, it can be issued by anyone. We're talking about behavioral health, social worker, psychologist, psychiatrist. The second signature though is always a physician, and usually they may not even be a psychiatrist, so it could be anybody. And often in given MPS, you may have you know, a handful of those, the second signature authority persons. And in operational unit, typically in the Army, we may delegate the division surgeon to second, sign or co-sign all of the medical in the division so that they have, it's a fortunate function for them to have visibility on what's going on within the division. That's what I see.
My read of this is that if the referral is placed by somebody who's not a doctorate level psychologist or psychiatrist, and it involves a mental health diagnosis, it needs to be reviewed and concurred by one of those credentialed providers. That's my interpretation. And that's what I've seen in the past. Is when I have done that, I've had to have an addendum written by a provider with one of those credentials. So. I put this back in this one. I had it in the previous presentation too, but because it's the same website, these are the people you can contact for help. The Lindu Smart Help Desk is really helpful. So if you have any issues with getting on, use that resource. Local medical boards offices to kind of lend it over into that as well are also enormous resources. But something weird always happens. You have somebody on a med board, they have a positive UDS for marijuana, and the command calls you and says, well, they're on a med board, what do we do? So if you have like weird stuff come up, the med board office at your, either at your duty station or nearby can be a wealth of information. But here, these are our local folks that you can contact for issues or questions. These are the references that kind of scattered throughout those 5 questions that I outlined. So you can go to these. One of the objectives I didn't list on there, but I probably should have, because maybe it's the most important, is knowing where to go to answer these questions. And so being able to find the answer to your question that you have, that something weird will always come up, having a list of these resources will be very useful. So knowing where to go to find answers is key. Using your resources like your med board's office is important. I do want to say 2 things that kind of came up in Landon's talk that I didn't put in here, but I think are important. The first is you alluded to the fact that I was shocked the number of people who thought that when we referred them to medical board, the PEB, they thought that was going to be the end of their treatment. And they would ask me, well, can I still get treated for this? And I was, of course. I mean, there really is like a perception that it's, kicking you out the door and not taking care of you anymore. So make that point clear to people is that even if they are going to get referred to a PEB, that they're still going to be provided medical care while that process is ongoing. Because it may seem obvious to you, but I was shocked when a number of people that was not obvious to them. And the second point is, at the end of the day, limited duty and medical boards are an administrative function. At least in the Marine Corps, there's an S1 person whose job it is to track and manage things. And in the Marine Corps, by instruction, is supposed to be an E6 or higher. And that person has a direct line of communication with the med board's office at whatever MTF is nearby. And it can be, you can get a lot of questions about medical boards because medical is in the title. What I try to do, what I would encourage others to do is to not get too in the weeds on the administrative side of things and delegate that to either physical evaluation work liaison officers, PEBLOs, or the local commands that you're working with, their Lindu Medical Board office. Because there are people whose job it is to track those things administratively.
I just reemphasize the Lindu number. If you call it, a person will pick up, which is awesome. And they will help you with like anything.
Yeah.
They're very knowledgeable. They can like go into the profile you made, like edit it, and change it. So if you have any concerns, any questions, if you're doing that, 100% call them and they're great.
Yeah. They really do pick up every time. So. And then I think just the cases are written. So we have a few cases that I put together to kind of run through. All right, what's the first one?
Do you want to do a break first?
Sorry?
you want to continue to do some cases now, you're gonna take a break first.
5 minutes.
Yeah, let's have that. Do then when they come back, we'll have them do some cases, then we'll do feedback and evaluation, and then we'll do Q&A.
Perfect.
Perfect. Okay, so before you run away to